Healthcare risk management scenario. Failure to use two patient identifiers. In a busy outpatient infusion clinic, nurses are preparing to administer chemotherapy to multiple patients scheduled in the same morning. The workflow is rushed, and a newly onboarded nurse feels pressured to keep pace with senior staff. A nurse receives medication prepared for John Williams, a 62-year-old male with colon cancer. She approaches a patient in Bay 3, greets him with, "Hi, Mr. Williams, I have your chemo ready." The patient smiles and nods politely. The nurse does not confirm with two identifiers, full name plus date of birth, only relying on the patient's verbal acknowledgement of his last name. Unbeknownst to her, the man sitting in Bay 3 is David Williams, a 67-year-old male scheduled for hydration therapy. Both men share the same last name, are around the same age, and arrived within minutes of each other. The nurse administers the chemotherapy infusion to the wrong patient. Consequences. Clinical harm. David receives a high-dose chemotherapy drug not intended for him, putting him at immediate risk of toxic side effects. Meanwhile, John does not receive his scheduled treatment, delaying cancer care, legal and regulatory exposure. The hospital is now at risk of litigation for negligence, violation of the Joint Commission standards, and potential CMS penalties. Reputation impact. The error leads to loss of patient trust, negative press, and damage to the facility's public image. Emotional toll. Both patients and their families experience distress, and the nurse is traumatized by the preventable mistake. Root causes. Failure to follow the two-patient identifiers protocol, name plus DOB, medical record number, or wristband scan. Over-reliance on patient acknowledgement instead of verification. Workflow pressure leading to shortcuts. Lack of reinforcement of policy during orientation. Risk management actions. 1. Immediate. Provide urgent medical treatment to David. Notify physicians, risk management, and patient safety teams. Disclose error to both patients and families. 2. Short-term. Conduct a root cause analysis. Retrain staff on two patient identifiers. Implement barcode scanning for medications. 3. Long-term. Embed hard stops in the electronic health record, EHR, requiring confirmation of identifiers. Foster a safety culture where staff feel comfortable slowing down to verify. Audit compliance regularly with spot checks. Was this helpful? A nurse gives a patient medication without checking the allergy band or list of allergies in EHR. The patient struggles to breathe and goes into respiratory distress. The charge nurse passes by and hears the commotion. She enters the room to find the patient in distress and the nurse frozen with panic. The charge nurse quickly realizes that the nurse is holding the contents of the medication, named as an allergy, on the patient's armband. She calls a code and epinephrine is administered to reverse the anaphylactic reaction. Healthcare processes aren't just policies. They're the protection for you and the patient. Healthcare risk management scenario. When just go in your brief becomes a lawsuit. Mrs. H, an 84-year-old long-term care resident, presses her call light. She needs the bathroom. The CNA, already covering 2 extra halls due to short staffing, responds, "Just go in your brief, we'll change you later." Mrs. H hesitates. She has always valued dignity and independence. But with no help in sight, she complies. Hours pass. The wet brief is not changed promptly. Mrs. H is left sitting in moisture, unable to reposition herself in bed. By the end of the week, a red spot appears on her buttocks. Within days, it progresses to a stage 3 pressure injury. The risk management breakdown. 1. Patient dignity ignored. A basic human request was dismissed. This eroded trust between patient and caregiver. Staffing and workload pressures. The CNA wasn't negligent in spirit, they were drowning in workload. But the failure to escalate or document refusal exposed the facility. 3. System gaps. Lack of a timely rounding protocol. No checks to ensure briefs were changed at required intervals. 4. Financial and legal fallout. Pressure injuries cost facilities $2,900, $151,700 per case, per AHRQ. Families view this as neglect and pursue legal action. Insurers flag the facility for high-risk patterns, raising liability premiums. The bigger picture: this wasn't just a pressure ulcer. It was a quality failure, a compliance violation, a risk management nightmare, a human dignity issue. Every preventable injury like this signals a system failure, not just a staff error. The lesson for leaders: dignity is safety. Responding to toileting needs prevents pressure injuries. Small moments matter. A 3-minute bathroom trip saves thousands in treatment costs. Risk managers must see patterns. If staff are saying just go in your brief, it's not one employee problem, it's a culture, staffing, and training issue.